You've seen it happen, right? Maybe watching sports, a sudden twist or a fall, and someone clutches their shoulder. Or perhaps you've even felt that jarring sensation yourself, that feeling that something just isn't quite where it should be.
Yeah.
We're talking about shoulder injuries, and today we're taking a deep dive into a really, really common issue: shoulder instability.
And it is incredibly common. When we talk about shoulder instability, we mean the ball of the shoulder joint, the humeral head, it's moving excessively in its socket, the glenoid.
Okay.
That can feel like just a slight slip,
Yeah.
or it can be a complete dislocation.
Right.
And just to give you a sense of how often this happens, shoulder dislocations, well, they account for about half of all major joint dislocations people experience.
Half. Wow.
Yeah, it's a big deal in the world of musculoskeletal problems.
Half. That's a huge number. So why is the shoulder specifically so prone to this compared to, say, your hip?
Well, it really comes down to the shoulder's incredible design for movement. Just think about the range of motion you have in your shoulder. You can reach overhead, behind you, across your body.
Everywhere, basically.
Exactly. And to achieve that, the socket part, the glenoid cavity, it's relatively shallow. The ball, the humeral head, only connects with a pretty small part of it at any given time.
Ah, okay. So it's built for amazing flexibility, but maybe that comes at the cost of, like, bony stability?
Precisely. That's the trade-off. Because the bones don't provide a lot of natural constraint, the joint relies very heavily on soft tissues, things like the joint capsule and the ligaments, to hold everything together and keep it stable.
Right. The soft stuff does the heavy lifting for stability.
Yeah. And if those soft tissues get damaged or are just naturally loose, that's where instability can arise.
That makes sense. Our source breaks down the causes into two main types: traumatic and atraumatic. Could you walk me through the difference?
Sure. So traumatic instability is probably what most people picture. It results from a specific, often significant injury, a fall onto the arm, a tackle in sports, a forceful impact that basically pushes the shoulder out of place.
Okay.
Our source notes that up to 96% of initial dislocations actually fall into this traumatic category.
So like that sports tackle you mentioned earlier.
Exactly. Contact sports injuries are a major driver, especially for young athletes. Traumatic anterior dislocations are really common in these cases.
Interior meaning it pops out the front.
Right, pops out the front. And it often happens when the arm is forced backward while it's, lifted away from the body and rotated outwards.
That classic vulnerable position.
Yeah, that specific mechanism is a major predictor of recurrent instability, meaning it's much more likely to happen again, especially in young, active people.
Okay, so that's traumatic, a clear injury event. What about the other type, atraumatic? That sounds different.
It is different because it doesn't necessarily involve a big single injury event. It's often linked to generalized ligament laxity, essentially. Someone's ligaments are naturally more stretchy or loose throughout their body.
So just built that way sometimes.
Exactly. Or if you see a dislocation happen without significant trauma, doctors will start to consider underlying conditions like connective tissue disorders, maybe something like Ehlers-Danlos syndrome.
Ah, okay.
Or even sometimes a subtle bony abnormality in the glenoid socket itself that just makes it less inherently stable.
Interesting. So it's not always about a specific forceful event. Who is most likely to experience shoulder instability? What does the epidemiology look like?
Yeah, the numbers are quite striking. It's most common in young males, generally between 20 and 30 years old.
Young men mostly?
Mostly. The source gives a male-to-female ratio of about 9-to-1.
Wow, 9-to-1. That's a huge difference. Why do you think that is? Activity levels?
That's likely a big factor, yeah. Involvement in contact sports and certain types of physical activity during those years. And regarding direction, anterior dislocations, where the humeral head goes forward and out, they make up the vast majority, about 95% of cases.
And the other way, posterior.
Posterior dislocations going backward are much rarer. Only around 2 to 4%.
Okay, let's think about what actually happens during a traumatic dislocation, especially an anterior one, since they're so common. We talked about the soft tissue stabilizers, the ligaments, the labrum, even the rotator cuff muscles acting dynamically. When that ball pops out, what structures are typically getting damaged according to the source? This is where it gets really interesting.
Yeah, this is key because these associated injuries often dictate how the instability is treated down the line. In an anterior dislocation, the most common associated injury is called a Bankart lesion.
A Bankart lesion. What exactly is that?
So the labrum is that rim of cartilage that kind of deepens the glenoid socket, makes it more like a cup.
Okay.
A Bankart lesion is a tear of that labrum, specifically at the front and bottom part. It gets pulled away or avulsed from the bone.
So it rips off the rim?
Essentially, yes. And if a piece of the glenoid bone itself breaks off along with that labrum tear, that's called a bony Bankart lesion.
Okay, sounds more serious.
It often is because it reduces the effective size of the socket, making it even less stable.
Got it. So the labrum gets torn off the front. What about the Hill-Sachs lesion? I hear that one mentioned a lot too.
Right. The Hill-Sachs lesion happens on the humeral head itself, the ball part.
Yeah.
As the ball dislocates forward,
Yeah.
the back surface of that humeral head slams into the front bony rim of the glenoid socket.
Ouch.
Yeah, and that impact causes an indentation or a divot in the bone on the back of the humeral head.
Like a dent from the impact.
Exactly like a dent. Just quickly, in the much rarer posterior dislocation, you can get the opposite, a reverse Hill-Sachs lesion on the front of the humeral head as it hits the back rim of the glenoid.
Makes sense. And what about TELIP tears? Are they related?
They can be. A TELIP tear is a tear of the labrum, but usually higher up at the top part where the biceps tendon attaches.
Okay, different spot.
Right. It can happen from things like falling onto an outstretched arm or repetitive overhead motions, like in throwing athletes, but it can also occur with dislocations, especially if there's a significant pull or force transmitted through that biceps tendon during the event.
The source also mentions greater tuberosity fractures and rotator cuff tears, particularly in older patients.
Yes, and that's a really crucial point about age. While Bankart and Hill-Sachs lesions are very common in, say, young athletes with traumatic dislocations,
Right.
in patients over 50 who dislocate their shoulder, you're much more likely to see a fracture of the greater tuberosity. That's a part of the humeral head where some important rotator cuff tendons attach.
Ah, so the bone breaks instead of just the labrum tearing.
Or in addition to other things, yeah.
Yeah.
And rotator cuff tears themselves become significantly more common as a complication after age 40 in patients who dislocate. The pattern of injury really shifts with age.
That's a critical insight. So, with all these potential injuries floating around, Bankart, Hill-Sachs, cuff tears, how does a doctor actually figure out exactly what's going on and what kind of instability you have?
Diagnosis is often clinical first, meaning it really starts with listening closely to the patient's story and doing a careful physical examination of the shoulder.
Okay.
Then, imaging is used to confirm the findings and get a detailed look at the specific damage.
What kind of history are they digging into? What do they want to know?
We want a really detailed story. How did the injury happen? Was it a specific event or did it just start feeling loose over time? Critically, how old were you the first time it happened?
Why is the age of first dislocation so important?
Because it correlates strongly with the risk of it happening again. Younger age usually means higher recurrence risk.
Got it. What else?
Has it happened again since the first time and how often? Do you ever feel like it's slipping or giving way even if it doesn't fully dislocate? That's called subluxation. And some patients describe a dead arm sensation right after the injury, which can be a clue about potential nerve involvement.
And the physical exam, what are they looking for there?
Well, first they'll look at how you're holding your arm. Sometimes the position itself suggests a dislocation, like holding it slightly away from the body and rotated outwards for an anterior dislocation.
Right.
But a really, really important part, especially right after an acute anterior dislocation happens, is checking the axillary nerve.
Why that specific nerve? What does it do?
It wraps around the neck of the humerus, so it's very vulnerable to being stretched or injured when the humeral head dislocates anteriorly. It's the nerve most commonly affected.
And how do they test it?
They'll test sensation over the side of your shoulder, the deltoid muscle area, and check if you can actively lift your arm out to the side, which is a key function of the deltoid powered by that nerve.
Okay. And there are also those specific tests they do to provoke the instability, right? Like the sulcus sign or the apprehension test.
Exactly. Those special tests help pinpoint the type and direction of instability. The sulcus sign is a simple one where the doctor gently pulls down on your arm while you're sitting or standing.
And what are they looking for?
If they see a noticeable gap or indentation, a sulcus appearing just below the acromion, that bony point on top of your shoulder,
Yeah.
if that gap is more than about a centimeter, it suggests general shoulder laxity or looseness. If the gap is more than 2 centimeters, the source says that's actually quite predictive of multidirectional instability, meaning it's loose in multiple directions.
Okay, that's for general looseness. What about the apprehension test?
That one's really useful, specifically for anterior instability. The examiner carefully puts your arm into that vulnerable position we talked about, abducted, so away from your side, and externally rotated.
The position where it might pop out.
Exactly. And if doing that makes you feel apprehensive, like you genuinely feel the shoulder is about to dislocate again, the test is considered positive.
And there are variations, too.
Yes, like the relocation test. If the apprehension test is positive, the examiner might then apply pressure to the front of your shoulder, pushing the humeral head backward. If that pressure relieves your feeling of apprehension,
Then it confirms it was about to slip forward.
precisely, it helps confirm that anterior instability.
And they're also looking for rotator cuff issues during the exam you mentioned, especially in older patients.
Yes, definitely. The source notes that in older patients, there are specific physical exam findings related to strength and movement that, if present, make a rotator cuff tear highly likely. So they'll be specifically testing for those signs.
Okay, so history and a bunch of specific tests. Then imaging comes in to back things up or get more detail.
Right. X-rays are usually first step, especially in an acute setting. They confirm if there's a dislocation, which way it went, anterior or posterior.
And check for broken bones.
Critically important, yes. They checked for those bony injuries we discussed, like bony Bankart lesions or greater tuberosity fractures. Specific X-ray views, like a true AP and lateral, or maybe a West Point view, help get the best look at these areas.
And for the soft tissue stuff you mentioned, like the labral tears or the rotator cuff tears, X-rays don't show those well, right?
Correct. X-rays primarily show bone, so that's where ultrasound or MRI come in. If a rotator cuff tear is suspected based on the exam, particularly in an older patient, ultrasound can be a good, quick way to check.
But MRI is kind of the gold standard.
MRI, especially MR arthrogram, where they inject dye into the joint, is generally the best for visualizing all the soft tissue damage in detail, seeing the labral tears, assessing the capsule, looking closely at the rotator cuff tendons and the biceps tendon. It really confirms those soft tissue and subtle bony injuries.
Okay, so once they've done the history, the exam, the imaging, and they know what is going on, how do doctors actually manage shoulder instability? What's the game plan?
Well, the immediate goal, if the joint is actually dislocated right now, is getting it back in. That's called reduction, and doing it as quickly as possible.
Why the urgency? What happens if you wait?
Two main reasons for speed. First, to minimize any further potential damage to the surrounding structures, nerves, blood vessels, cartilage. Second, to prevent the muscles around the shoulder from going into intense spasm.
Spasm makes it harder to put back.
Much harder, yeah. Often requiring stronger medication or even anesthesia if you wait too long. And remember, you check that axillary nerve function carefully before attempting reduction and immediately after it's back in.
Right, crucial step. How do they actually put it back in? Is it like in the movies where someone just yanks it?
Hopefully not quite like that. There are various established techniques. A very common and practical one is traction-countertraction. Basically, one person gently pulls on the arm in line with the body, while another person provides countertraction, maybe with a sheet around the patient's chest, to stabilize the body.
Okay, a controlled pull.
Exactly. And after it's successfully reduced, you check that nerve function again, and you thoroughly reevaluate for other injuries, like rotator cuff tears or subtle fractures, especially in patients over 30 or 40.
So reduction first. Is surgery always the next step once it's back in place?
Not necessarily. Non-operative care is certainly an option, maybe if surgery is declined or not readily available or depending on the situation.
Okay.
But here's a really interesting detail from the source. Specifically, for first-time traumatic anterior dislocations with a confirmed Bankart lesion, they recommend immobilizing the arm for about 3 weeks, day and night, but not in a standard sling.
Not a standard sling. I thought that was standard practice. Why not?
It's a key point.
Okay.
Because a standard sling holds your arm close to your body, rotated inward internal rotation.
All right.
The source emphasizes immobilizing in external rotation, often using a special pillow or brace that holds the arm slightly away from the body and rotated outward.
Why external rotation? What does that do?
The thinking is that external rotation actually helps bring the edges of that torn Bankart lesion back closer to its attachment site on the glenoid bone. It potentially improves the chances of healing in a better position and might reduce the risk of it happening again.
Whereas the standard sling?
The standard sling with internal rotation tends to open up that anterior gap and pull the torn labrum further away from where it needs to heal. So that specific positioning post-reduction is a really important takeaway from this source.
Wow, that's a surprising detail. I would have absolutely assumed a standard sling. Good to know.
It's a significant point they highlight. Now, shifting gears, for that other type, atraumatic multidirectional instability, the loose shoulder without a big injury.
Yeah.
The first-line management there is often quite different now compared to maybe years ago.
How so? Less surgery,
Generally, yes, at least initially. Surgery used to be considered more readily, but the approach has shifted. The primary first-line treatment is now typically non-operative physiotherapy.
Physical therapy.
Yes, but very specific, targeted physiotherapy focusing on strengthening the dynamic stabilizers, the rotator cuff muscles, and all the muscles that control the shoulder blade, the scapular muscles.
Okay, strengthening the muscles around it.
Exactly. The goal is to improve muscular control and stability actively, rather than just relying on surgery to passively tighten things up. This is usually a dedicated program lasting, say, 3 to 6 months.
So physio first for the atraumatic, loose folks, and that specific external rotation bracing for the traumatic Bankart folks. When does surgery become the main recommendation?
Surgery is often offered and sometimes strongly recommended after even a single traumatic dislocation, particularly in young, active individuals, say, under 40, especially those involved in sports.
Why the lower threshold for them?
Because their risk of having the shoulder dislocate again is significantly higher compared to older or less active people. Recurrence rates can be very high in that young athletic group if managed non-operatively.
Okay, and what does that surgery typically involve if they go that route?
For the common Bankart lesion, the standard procedure nowadays is usually an arthroscopic repair.
Keyhole surgery?
Exactly. Minimally invasive, using small incisions and a camera. The surgeon uses tiny suture anchors, little devices that go into the bone with sutures attached, to basically reattach the torn labrum and capsule back securely to the bone rim of the glenoid socket.
Sewing it back where it belongs.
Pretty much, yeah. It's often done as day surgery, relatively low morbidity. And the success rates in experienced hands are reported as very high, often over 95%.
That sounds pretty good. What are the main risks or complications?
The main complication is still the possibility of recurrent dislocation, unfortunately. That risk is higher if there was significant bone loss from the start, either on the glenoid, bony Bankart, or the humeral head, large Hillfax.
Okay. And if there's a rotator cuff tear involved, like you mentioned in older patients, do they fix that at the same time?
Yes, absolutely. If a significant rotator cuff tear is present, particularly in that older age group where it's more common with dislocations, the surgery would likely involve repairing those torn tendons as well, often arthroscopically too.
Got it. Let's quickly touch on rehab after surgery. It's not like you have the surgery and you're back to normal the next week, right? What's that general timeline look like?
Definitely not. Rehab is crucial and takes time. Typically, patients wear a sling, at least during the day for comfort and protection, for about 6 weeks.
6 weeks in a sling.
Yeah, but they start some gentle motion early. Things like hand grip exercises, maybe gently moving the shoulder blade, doing pendulum swings where you just let the arm hang and gently swing.
Okay, some movement is good.
Yes, passive range of motion often starts quite early, guided by the therapist. Then, around 6 weeks, they usually progress to more active assisted stretching and start using resistance bands, gradually building up over the next few months, maybe up to 3 months post-op.
And when can you start actually lifting weights or getting back to more strenuous activity?
Lifting anything significant with that arm is generally avoided for at least the first 6 weeks, sometimes longer depending on the repair. Lightweight strengthening usually begins around the 3-month mark.
And things like sports.
Returning to demanding activities, like contact sports or heavy work duties involving the shoulder, is often a much longer process, typically guided by the surgeon and therapist. It's often 6 months or even longer, and really depends on regaining strength, stability, and confidence in the shoulder. You definitely need clearance before going back to high-risk activities.
Makes sense. It's a commitment. And what happens if instability isn't treated effectively over the long haul, if someone just keeps having dislocations or subluxations?
The long-term consequences of recurrent untreated instability can be pretty significant. It often leads to chronic ongoing pain. But, maybe more importantly, it can contribute to the premature development of osteoarthritis in the shoulder joint.
Arthritis. Why?
Because that repeated abnormal motion, the slipping and sliding of the joint surfaces, causes increased wear and tear on the cartilage over time.
So addressing the instability can potentially help prevent arthritis later on.
That's certainly one of the long-term goals, yes.
Our source also gives a few brief case examples that kind of help illustrate these different scenarios we've been talking about.
Yeah, they're helpful.
Like you have someone we can call John, maybe a 20-year-old rugby player. He's had multiple traumatic anterior dislocations. Imaging shows a clear Bankart lesion.
Right. For John, given his age, activity level, traumatic mechanism, and recurrent instability with a known structural lesion, his likely path, based on the high recurrence risk, would almost certainly lean towards surgical Bankart repair.
Okay, contrast that with, say, Sarah, maybe a 60-year-old woman who dislocates her shoulder for the first time after a simple fall at home. She has an anterior dislocation.
Right. For Sarah, yes, the first step is reduction and checking her nerve function carefully. But the focus in her evaluation after reduction is going to be very high on specifically looking for a rotator cuff tear or a greater tuberosity fracture.
Because those are more common in her age group.
Exactly. And finding one of those would significantly guide her subsequent treatment. She might need surgery to repair the rotator cuff rather than just focusing on the instability itself initially.
Got it. And then there's a third type, maybe Sally, a young gymnast who didn't have one specific big injury but has pain in both shoulders and feels like they're constantly slipping or feeling unstable. Her exam shows general joint laxity, maybe a positive sulcus sign bilaterally, and tests for multidirectional instability are positive. Imaging shows a loose capsule but no big traumatic tear like a Bankart.
Yeah, Sally's case sounds like a classic example of that atraumatic multidirectional instability, MDI. And as we discussed, the initial and often the most successful long-term treatment for her would be that dedicated, targeted physiotherapy program focusing on strengthening her dynamic stabilizers, the rotator cuff, and scapular muscles.
So probably not rushing to surgery for her.
Probably not as the first step, no. The evidence really supports trying extensive, high-quality physio first for MDI. These cases really highlight how the approach isn't one-size-fits-all. It's very much tailored based on the cause, your age, your activity level, and the specific structures that are actually damaged inside the shoulder.
So to kind of wrap this deep dive up, we've seen how shoulder instability, which is super common, often stems from the shoulder's really unique anatomy, how it prioritizes incredible motion.
Yeah, at the expense of some inherent bony stability.
Right, making it so reliant on those soft tissues, the ligaments, labrum, muscles. We've explored the difference between traumatic injuries like falls or tackles, leading to specific structural damage like Bankart and Hill-Sachs lesions, and those atraumatic issues, often linked to underlying looseness or laxity, presenting more as multidirectional instability.
And we've covered how doctors diagnose it, starting with your story, the mechanism of injury, your symptoms, then moving to those specific physical tests to pinpoint the type of instability and check for associated injuries like nerve issues or cuff tears.
Right, like the apprehension test, the sulcus sign.
Exactly. And then using imaging like X-rays to see the bones and confirm reduction, and MRI or ultrasound to get a detailed look at the soft tissues, the labrum, the tendons.
And finally, how the management strategies vary so widely, from the urgent need for reduction in acute dislocation.
Get it back in quickly and safely.
Followed by potentially surprising immobilization techniques like that external rotation bracing for traumatic Bankart tears instead of a standard sling.
Yeah, that was a key point.
To that focused, non-operative physiotherapy being the first line for atraumatic instability. And then considering surgery, especially for those young, active individuals with recurrent traumatic dislocations, or for significant associated injuries like large rotator cuff tears, particularly in older patients.
Absolutely. Understanding these different facets, the causes, the diagnoses, the tailored treatments, is incredibly valuable, whether you're personally navigating a shoulder issue, or you know someone who is, or you're simply fascinated by the complex mechanics of the human body and how medical professionals approach trying to fix things when that delicate balance is disrupted.
So what does this all really mean for us thinking about our own bodies?
I think it means the shoulder is just a masterclass in biological engineering, isn't it? It grants us this incredible freedom of movement, lets us reach and throw and interact with the world in amazing ways. But it asks us to accept a degree of inherent instability in return.
That trade-off again.
Exactly. It's a joint constantly balancing the need for that vast range of motion with the fundamental need to stay securely in place. This deep dive really shows us the many ways that delicate balance can be upset, whether by sudden injury or by our underlying structure. Kind of makes you wonder, doesn't it? What other joints in the body face similar kinds of trade-offs between maximizing function and maintaining stability, and what are the unique challenges they present when that balance is ultimately lost?